podcast is brought to you by Box & Co. Luxury reimagined.
Welcome to Quaderno Academy, empowering excellence through education. Join us as we inspire growth and unleash your potential. Let's dive in.
Welcome to the deep dive. Today, we are wading into one of the most stressful decisions a family can face. We're talking about post-hospital care. You know, if you or someone you love needs to recover after a big health event, you're suddenly drowning in this alphabet soup of facilities.
Oh, absolutely. SNFs, LTACHs, IRFs.
Exactly. And they're all governed by these really strict, kind of obscure Medicare rules. The whole system feels like it's designed to confuse you right when you're at your most vulnerable.
Right.
Okay, let's unpack this. We've gone through the sources to bring you some clarity on, I think, three really essential areas.
Okay.
First, the technical definitions of these places, then the stunning reality of the costs, and finally, the absolutely non-negotiable patient rights you have to be ready to assert. Our mission today is to replace that panic with knowledge.
And that knowledge is, well, it's not just theoretical. We have to start with a pretty startling statistic. An individual who turns 65 today has, get this, a 70% chance of needing some form of long-term care in their future.
70%, wow.
So this deep dive, it's essential prep work, whether you need it today or 10 years from now. Knowing where you go after the hospital and who pays for it, that's half the battle right there.
So let's start with decoding the environment. Most of us just use the phrase nursing home for everything, right? But the technical distinction between a nursing home and a skilled nursing facility, an SNF, that matters a lot.
It matters profoundly, especially for payment. An SNF is basically a medical bridge. It's there to provide medical services and complex care for people recovering from a severe illness or injury.
So like after a stroke or a big surgery.
Exactly. Think rehabilitation after a major joint replacement, recovery from a serious stroke, or maybe complex IVs and wound care. The key is that it has to involve daily skilled services that you just can't practically get at home.
Okay, so if we're looking at the whole spectrum of recovery, where does an SNF actually sit compared to the other more intense options?
You can think of it in, say, 3 tiers of intensity, almost like different kinds of specialized hospitals. At the very top, you have the highest intensity medical environments. Those are the long-term acute care hospitals, or LTCH.
LTCHs, so those are basically just extensions of the hospital itself, right?
Precisely. LTCHs are for the most clinically complex patients. They might need to be weaned off a ventilator, or they need management for multiple failing systems. Patients in an LTCH usually stay for several weeks, and they need a physician to see them every single day. That's the top tier.
And then you have the places that are less about complex medicine and more about intense physical rebuilding, the Inpatient Rehabilitation Facilities, IRFs.
An IRF is that second tier. It's dedicated almost entirely to aggressive, high-volume therapy, helping patients get function back after something like a brain injury or a major amputation.
Right.
If you go to an IRF, you're basically making a commitment. You have to do intensive rehab sessions for at least 3 hours a day, 5 days a week.
It's a full-time job.
It is.
So to simplify this for everyone listening, LTCH is for acute, complex medical stabilization. IRF is like a high-intensity physical therapy boot camp. The SNF, then, is that third tier. It's the transitional step for people who need daily medical care but don't need that super aggressive LTCH or IRF level before they can safely go home.
That's the perfect summary.
Okay, let's pivot from the clinical side to the costs. Here's where it gets really interesting, and you should probably prepare yourself for the sticker shock. Based on 2025 national median numbers, what are we talking about per year for SNF care?
The median national daily cost for a private room is $361
A day.
If you stretch that out, the median national annual cost for a private room hits $131,583. Even a semi-private room, sharing with someone, averages about $9,555 a month. That's a huge financial exposure for any family.
That $131,000 figure, let's just push this right back to that 70% statistic you mentioned. This is a financial cliff waiting for most seniors. And it sounds like location is the biggest factor here.
It's massive. Costs are driven by geography, sure, but also the type of room, private versus semi-private. And whether a place markets itself as being, specialized or luxury, the state you live in can change your bill by tens of thousands of dollars a month.
The sources really highlight that variance. I mean, you have the most expensive state, Alaska, where a semi-private room is an astonishing $31,282 a month.
$31,000.
Compare that to the most affordable state, Texas, where that same room is just $5,639 a month.
And this disparity exists even within a single state. Take Florida. A semi-private room can be about $9,164 a month in Gainesville, but just a few hours away in Port St. Lucie, it's over $15,383 a month.
That's just hard to wrap your head around. It suggests that if you live near a state border, moving a few miles could save you 20 grand a month.
It could, and these numbers are only going up. Genworth estimates at least a 3% annual inflation rate for this kind of care. So if we project that out to 2033, the median national cost for that semi-private room is expected to be about $12,104 per month.
Planning is no longer optional. So how do we pay for this? The critical source of funding for medically necessary SNF care is Medicare Part A. And that's the good news, but it comes with tripwires. The most notorious one is the 3-day prior hospitalization rule.
The 3-day rule is, it's the absolute cornerstone of coverage. To qualify for Medicare Part A to pay for SNF services, you must have been an inpatient in a hospital for a medically necessary stay of at least 3 consecutive calendar days.
3 consecutive days.
Without those 3 days, Medicare Part A it won't open the door to SNF coverage, period.
And this brings us to a huge pitfall the sources point out: observation status. Time you spend in observation or in the ER before you're formally admitted as an inpatient does not count.
It does not count. And this is where so many patients get trapped. Hospitals use observation status for their own reasons, to avoid readmission penalties. But it can accidentally shift the whole financial burden onto the patient if they need an SNF.
So you think you've been in the hospital for 3 days?
But if 2 of those days were coded as observation, you don't qualify. You're out of luck.
So here's the actionable advice, the defense mechanism for you listening. If you're admitted to the hospital and you think you'll need SNF care, you have to ask your doctor or case manager immediately, am I formally admitted as an inpatient or am I under observation?
That is the essential question. If you're under observation and the team says you'll need an SNF, you have to advocate for yourself. Either push for inpatient status, or you have to recognize you'll be footing that SNF bill yourself, maybe with long-term care insurance or Medicaid.
Okay, so let's say you clear that 3-day hurdle, you get into the SNF. Coverage then depends on the kind of care you're getting every day. Medicare covers daily skilled services. What does that actually mean?
It means the care has to require the specialized skills of, say, a nurse or a therapist, something that needs a professional to be done safely and effectively. This covers things like physical therapy, occupational therapy, IV injections, that sort of thing.
But if you only need help with basic living activities, what they call custodial care, that's not covered.
Correct. If your only need is help with what they call activities of daily living, bathing, dressing, eating, Medicare won't cover the stay. However, and this is a really important distinction, if you do qualify for coverage because you need daily skilled services, then Medicare covers everything else, including that custodial care.
Because you have to be there anyway.
Exactly, because you're required to be there on an inpatient basis.
Now, what happens if the facility says the patient has, plateaued? If you aren't getting better, can they just legally kick you out and cut off Medicare?
This is where we have to talk about the GMO standard. It's one of the most important concepts we'll cover today. For decades, Medicare would incorrectly deny coverage if patient wasn't showing potential for improvement. GMO changed that.
The GMO standard says that skilled services are covered even if the goal isn't recovery. Is that right?
That's it, exactly. Medicare coverage for skilled services is available if those services are necessary just to maintain the patient's current condition or maybe to slow further deterioration.
Can you give an example?
Sure. If a patient has advanced Parkinson's, a therapist might provide skilled services to maintain their range of motion or their ability to swallow. That prevents a decline. Even though they aren't improving, the high-level skills of that therapist are needed daily to maintain function, and therefore, coverage must continue.
That is critical. So if I'm told I just need custodial care and I'm losing my coverage, I need to know that I can legally bring up the GMO standard to the social worker.
Yes. You assert that the care is skilled because it's required for maintenance or to slow deterioration. It shifts the focus from improvement potential to the complexity of the service you actually need.
So, GMO protects the type of care you get. But your second major protection kicks in when they try to discharge you. Let's talk about that mandatory notice system.
This is your right to fight. The most critical notice is called the Important Message from Medicare, or the IM. You have to get this notice when you're admitted, or within 2 days, and then you get another copy just before they plan to discharge you.
And this notice explains your right to appeal, right? The expedited review, I've heard it called the nuclear option because it stops the discharge in its tracks.
It's swift, and you have to use it urgently. If you feel you're being discharged too soon from the hospital or the SNF, you have to request an expedited review with the Quality Improvement Organization, the QIO.
Okay, let's make this really actionable. Break it down into 3 urgent steps for our listener.
Step 1. Find that important message from Medicare notice. The QIO's phone number is printed right on it. Step 2. Call the QIO and file the review request no later than midnight of the day of discharge.
Midnight, that's a hard deadline.
It is. And step 3. Do not leave the hospital or the SNF. If you make that request in time, you are not financially on the hook for the inpatient services while the QIO reviews the case, other than your normal deductibles.
That's immense protection during a crisis. And what about your rights while you're actually in the SNF?
Federal law guarantees extensive resident rights, the right to be treated with dignity and respect, the right to participate in your own care plan, and the right to be free from abuse or from, physical or chemical restraints that are just used for staff convenience.
And there's a notice period for discharge there, too.
Yes. Federal law requires residents get 30 days advance notice of a transfer or discharge unless there's a real medical emergency. That 30-day window gives families crucial time to plan the next step.
And hopefully that next step is back home. I know there are programs like nursing home transition programs designed to help people move back into the community.
They exist in many states, and they're designed specifically for that, to empower people to move back to a home of their choice. They often use what are called home and community-based services waivers to help fund the support you'd need to make that move work.
So as we wrap this deep dive, let's just circle back to the core insights, the things you absolutely need to remember from all this.
Okay. Remember the distinctions. LTACH and IRF are highly specialized and intense. The SNF is the transition. Remember the steep and very different costs, which means you have to prepare financially. And crucially, internalize the Medicare 3-day inpatient stay rule.
Observation time does not count.
It does not count. And above all, know your appeal rights through that QIO process before you ever walk out that hospital door.
And here's one final provocative thought, which connects the necessity of this care with your long-term financial life. If an SNF stay is primarily for medical care, the entire cost of that stay, including the money spent on meals and lodging, is tax-deductible as a medical expense.
That's a vital piece of information.
It is, especially when you're dealing with those 6-figure annual costs. The sources confirm this pressure is only going to increase. With the aging population, the silver tsunami, we may need thousands of additional nursing homes just to keep up. Being informed now, before a crisis hits, gives you the power and the leverage you need to navigate this system. Thanks for joining us for this deep dive.
Brought to you by Quaderno KO. Learn smarter, not harder.